I'd like to be the first to welcome you to our webinar, Predicting and Preventing Claim, Fraud, Waste, and Abuse with Advanced Profiling and Analytics. Our agenda for today is listed here. Before we truly get going, I do have a few housekeeping items to cover. Then we will begin the content portion with the discussion of the market drivers we're seeing affect payers. Next, we will review our vision of analytics' role in helping meet these challenges that those drivers present. After that, we'll conclude the content portion with 3 use cases. And finally, we'll close our session today with our remaining time dedicated to a Q&A section. Throughout the webinar, we'll also have some polling questions to capture your input, so be on the lookout for those as well. During the hour, all participants will be in a listen-only mode. We do, however, encourage you to ask questions during the course of today's presentation. To do so, you'll simply submit your questions using the questions window located on the right side of the screen. Type your question into the box, click send, and they'll be sent directly to a meeting organizer to queue for the Q&A session we'll host at the end of the hour. Should you encounter any technical difficulties, please also use this questions window. Simply describe your issue, and one of our support staff will follow up with you to troubleshoot. Typically, I will say that most technical difficulties are a result of poor connections and can usually be resolved by exiting and then rejoining the webinar. Today's session has also been approved for 1 NHCAA CPE credit, so be on the lookout for a link in the follow-up email we will send to you in order to complete this part of the process. Today I'm pleased to be joined by 2 presenters with a wealth of experience on our topic. First, Roger Smith has over 16 years of operational and industry experience in healthcare, handling matters involving provider contracting, claims operations, provider and member dispute resolution, industry regulation, fraud, waste, and abuse investigation, and payment integrity. Roger has served in several key roles at CO, including running payment integrity operations, developing CO's analytic capabilities for payment integrity, and client solutioning. Dr. Blinsky has been with CO for 11 years and currently serves as a strategic account manager for PBM and health plan clients. At CO, she has held various positions, including Senior Vice President of Operations for Retail Pharmacy, where she created and managed the pharmacy audit programs. Prior to CO, she was the Chief Operating Officer for a regional home infusion, home health, and DME company. With that, I'll step aside for now and hand things over to our speakers. Rena?
Okay, thank you, Sean. Good afternoon and good morning, everyone. It's certainly a pleasure to be here with you today. So to kick us off, we wanted to provide some background as well as highlight some of the new market drivers that we are seeing at CO, as I'm sure many of you are seeing as well. As we know, the cost pressures in healthcare continue to mount for many reasons, some of which include specialty pharmacy, the aging population, personalized medicine. For example, we're seeing demands for lots of lab testing and things like that. And then the push to value-based care or outcomes-based care has also led to a vertical integration on the provider side, which really has given providers more pricing power. A lot of us have seen as hospitals acquire physician groups, we see a shift of specialty drugs, for example, being administered in the outpatient setting versus in the physician setting, which is a lot more expensive to the system. Also, in the last 2 years, there's been roughly 200 payviders that have formed, which is a provider and a payer coming together to take risk and participate in the outcomes-based care. So all of this brings a movement to bring diverse data together, but it's really not as easy as we all would hope, as I'm sure all of you know. There are EHR systems, new data types, lack of standardization that really make it difficult for us to get to where we need to get to in the fraud, waste, and abuse space. So this really presents a challenge to those of us that work in that space. And Roger, if you go to the next slide. So this also really is of no surprise to anyone, but putting this in perspective, our U.S. healthcare expenditures at $3 trillion is second only to financial services in the U.S. For total revenue. So also another perspective that if our healthcare spend in the U.S. Were a country, it would be the 5th largest economy in the world. So there is definitely lots of work ahead. And just a note on the data explosion as well that many of us see and hear about pretty much on a daily basis. The volume of worldwide healthcare data in 2012 was about 500 petabytes, and it is expected to grow to 25,000 petabytes by 2020. So it really is quite exponential in growth, and all of us, I'm sure, are experiencing that. North America is expected to maintain this lead position with Europe following behind. The key here really is that the industry is rapidly moving to beyond traditional data as a necessity to manage this outcomes-based or value-based care, but conversely to it being a challenge, we also believe that it can assist us with new insights into fraud, waste, and abuse that we really haven't had the chance to have before. So again, from a traditional perspective, these types of data sets that we're all very familiar with, members, providers, claim information, have been very successful. Some pockets of them have been extremely successful. But this look at traditional data is really not, in our opinion, not sustainable. Going claim by claim, certainly many SIUs that look at this and have historically looked at data this way have been very successful, but just given the sheer size of data and the disparate types of data, we don't think that this will be as sustainable nor as effective as we would like, and we really have to change our thought process and start looking at non-traditional types of data. So with that, I'm going to turn it over to Roger, who will speak to some of those non-traditional types of data, and I think before that, we might have a poll question.
Yes, thank you, Rena. We actually do have our first polling question of the day, so if we can go ahead and launch that, please. And the question, once it's up here, is this: what sources of data does your organization use to identify potential fraud, waste, and abuse patterns? So within this, please select all that apply. We have first claims data, second provider demographics, third member demographics, fourth would be behavioral or member or provider attitude information, and then if you're using something not listed here, we do have an option for other as well. Looks like, let's see, coming in about 45% of folks have voted, so we'll give just a few more moments. Okay, we're about to just over 60%. So let's go ahead and close the poll. If you would please share the results. And for our speakers who don't have the benefit of seeing these results, we have 98% use claims data, 58% use provider demographics, 51% would use member demographics as well, and then 31% are using behavioral or attitude information. So I'll leave it to our speakers if they have a comment on that. Would this be what you would expect, Roger, Rena, as for the audience around what types of data that they would use?
Sean, hey, it's Roger. Yeah. Oh, go ahead, Rena.
Go ahead.
I was just going to say it does make sense that the basis for a lot of the work that's been done historically has been claims data, so that virtually everybody uses that foundationally. Makes complete sense. And then as sort of you move up the different levels of data, folks are working to incorporate that into their analysis and their models and their work, but I think that's a little newer for a lot of folks that we're seeing and plans that we're seeing. Rena, I don't know if
Great.
you wanted to add to that.
I would agree. That's the same thing I was going to say.
Great. So thanks very much. I appreciate everybody sort of taking the time to answer the poll, and welcome again. Pleasure to have the time to speak to you all today. So in terms of the need for analytics, I think, again, relatively straightforward. Folks have been looking at fraud, waste, abuse for decades, and there's lots of really smart people with really good experience. The problem is, as you know, sort of demonstrated maybe by the CERT testing for one benchmark, it looks like problems persist, and in fact problems may actually be getting worse. You know, I don't know if this is sort of anecdotal and hard to really say whether, but it looks like even in the most recent years of 2014 and 2015, CMS's testing show that the error rate in their claims payments is higher than it was even several years before. But the baseline sort of view I think we take from that, and when we talk to folks, is you need to do more than what we're doing now. There's a lot of additional opportunity, but you know, there's been a lot of work, good work done, but there is more analysis and work to do to move this forward. And you know, you sort of can even watch what the federal government has done to improve their efforts. So you know, a couple dates I noted: in 1997, it was a big deal at the time when the federal government decided to invest $100 million to fight healthcare fraud. But 10 years later, it took before HHS, OIG, the U.S. Attorney's Office created really the first Medicare strike force. Of course, in South Florida, where many know that there are systemic and deep problems in healthcare fraud. And then in 2009, the HEAT team, Healthcare Fraud Prevention and Enforcement Action Team, was created, and it really became what many would describe as a cabinet-level priority for the federal government. And you know, even that 2009, it's been now for 7 years that there's been so much focus in the federal government, and I think, as the CERT testing shows, there's still a lot more to do, and there's traditional sort of methods are certainly finding overpayments and finding fraud, but there's a lot more opportunity, and there's more that folks need to do. So, and again, there's continued sophistication on the provider side, on the sort of fraudster side. That comes from new schemes of abuse, continued growth of new services that health plans have to keep up with, and frankly, the ability to receive millions of dollars. You know, we're in a system that trusts claims as they come in and pays them on their face without any verification in many cases. And so just experience alone is not enough. What really is necessary is some additional capability to sift through these huge data sets quickly, act quickly, and catch things early and identify patterns so that they can, the very smart people that exist in the industry can take action. So what our vision is basically taking nothing necessarily completely new, but sort of enhancing and building on existing tools and things. So as Rena talked about, you know, most folks have been doing some kind of analysis of provider behaviors compared to peers, some type of analysis of member activity, maybe looking for members that are high utilizers of certain services, or the entire member's family goes to the chiropractor every time, which is sort of an odd occurrence and a red flag. But is there additional data, additional analytics that can enhance that basic understanding of a member or members, groups of members, a provider or groups of providers? And it's all about, is their ability to better identify what are actionable patterns. They might be fraud, they might be waste, they might be abuse. So first step is finding things that merit review and reducing false positives. There's a limited number of resources, so those need to be prioritized. How do we help the people that exist within the industry go do work on the right things and the things that are going to be the most productive, so that overall performance can be improved? So on the provider side, certainly based on claims, but there's additional concepts around member risk, member demographic, linkage of providers that exist within the industry and are used in various settings, but aren't always, in our experience, really incorporated into analytics on the payment side to identify payment errors or risk claims that are high risk for error. And then on the member side, patient risk in terms of conditions that they have, comorbid conditions, what are their propensities, what are the demographic characteristics. Simplest example might be, what is their income level and can they afford the high coinsurance and deductibles that it would appear the services billed for them would carry with them, especially with high deductible plans. So there's information like that that is additive to the basic information that a lot of, and then how to weave those together to really identify additional problems, or for claims that have been identified, help prioritize those efforts, as I said. And just to graphically display this, so there's a bunch of different data sources that exist. The traditional ones are in sort of lighter blue here: medical claims, pharmacy claims, enrollment data, provider data. But there's a bunch of new information, as Rena mentioned. There's EHR data that is becoming available, although there are challenges there. Other types of clinical data, demographic data, whether it be from ZIP+4 data you can get on specific people, or about specific age groups, populations, people in different areas of the country, lab and biometric data, HRA and survey, activity data. And so the vision is taking all of that data together and building more robust patient and provider profiles through deeper analysis and transformation to then allow an analytics engine to be developed that can look at, on a more robust level, things like billing behavior, linkages and referrals patterns, what the patient populations are that are involved for that specific cohort, provider, group, and as well as audit outcomes and looping and incorporating those back in. Then, once a specific group of claims that might be at issue can be fed into that analytics engine, and recommendations can be returned for what are the items that are merit review, merit work, and then of course once work has been done, feeding that back, updating the provider profile, updating patient profiles to refine the ability to say, okay, what is a true actionable item and then what is potentially a false positive. At a very high level, there's a bunch of different ways obviously to analyze providers. This shows just a simple sort of what the risk of a provider is by error impact, a bunch of different categorizations. So grouping providers into cohorts of how many are very low risk, how many are very high risk, what are the average claims for those providers, what are the average overpayments for that provider group. These would be groupings to look at like providers. So even once you would have, same specialty, even within the specialty, there's going to be variation in behavior. So scoring and looking at providers on those categorizations. What's the overpayment average for that provider when they're audited? What's the appeal rate, uphold rate? And obviously, the very high risk providers, everybody knows to look at them. This is sort of a one could view this as a typical bell curve analysis where you're going to look at the people that are the highest utilizers. And that's been something folks have been looking at for a long time, as compared to their peers who uses service A a lot more than other providers. But there can be groups hidden within some of the middle tranches potentially that might be either high error rates, high overpayment. It's a subgroup that's hidden within, say, the moderate. So there's a reasonable number of providers there, but the overpayment is reasonably high for that group, and the average claims might be lower than the groups there around them. So there might be a better opportunity to focus in on a specific cell within that moderate group if you can get some additional information. Another area where we are seeing some good work is around using benchmarking information to try to inform some of these profiles, and trying really to do that at a national level. So gathering together data that is not just for a specific payer, not just for a specific product, not just for a specific region, but comparing regions. This specific example is billed amount per PCP visit. So there is a big variation on how much is billed for when a member across the United States goes to a primary care physician. And this is 80% of all claims data for the entire country. So looking at something like that can inform, okay, if the specific provider is in California versus Pennsylvania, you have different expectations as to what the baseline should look like. So whether that provider varies substantially from their peers, or whether there's almost a hot spot within that area where a lot of providers are overbilling, potentially overutilizing, a bunch of different ways to approach that. So really looking at those variations, digging down into product, market, and refining so that when you're looking at a specific comparison, to make that comparison more robust than just taking one payer's data or just taking data from a specific product and trying to look across that. And then on the member side, also developing these personas. So there's a lot of work that exists within healthcare to score members for various characteristics. And a lot of that is used on the utilization management side. So it's used by the medical management teams to identify people that need more management. They might have certain conditions, right? So there's scores of people as to whether they're diabetic, as to whether they are or at risk for diabetes. There's scores about whether they are at risk for admission to a hospital, whether they are at risk for an ER visit, whether they are at risk for various things. Those risk scores are additional information that exists that is not often brought into the payment side in our experience. So there are people that have a lot of chronic conditions. They are sicker. So one would expect them to have more intense services. So if, for example, one were looking at an inpatient stay for two different people, one that is a high-risk person who has a lot of chronic conditions and it's a very intense service, as opposed to another person that also has that similarly intensely billed service but has fewer chronic conditions or a lower risk of overall needing intense care, that is a factor that in fact can be used to evaluate whether that claim is at risk for an error. So looking, for example, there's the obvious chronic older adults and high-cost baby boomers that have a lot of conditions. They are relatively high utilizers, but there's also a group that might have fewer chronic conditions, in this example, the high utilizers, but they actually are the highest utilizers of ER services, inpatient services, and the PMPM paid is higher for them than it is for other cohorts. So the question is that legitimate? Are they just people who are nervous and go to their doctors more frequently, go to the emergency room more frequently? Or is, because they're not as risky people, is that in fact a situation where a provider is abusing and either there's a kickback situation involved, or the provider is just an abusive biller and the person doesn't realize that it looks like they're receiving more services than they actually are because there's error in the claims. So the key is, how can you use additional information about patient acuity, and as well as behavioral characteristics to slice and dice and identify pockets within specific groups that merit further review. And I think at this point we have our next poll question before we move on to our exemplar use cases.
We certainly do. So if we could go ahead and please launch our second poll question of the day. When that's up, the question is, sort of get a gauge on your organization, the sophistication in your use of analytics and data. Advanced analytics is what we're looking at. So would you consider early on considering the use of non-traditional analytics and data to identify those incidences of outliers to investigate for fraud, waste, and abuse, or in progress, perhaps you're in implementation phase? Advanced, we would consider already seeing some positive outcomes realized from using these new types of data, or an option here for not sure. Give folks just a few moments here. Looks like about 50% of people have voted so far. Okay, why don't we go ahead and close the poll as we get close to 60%. So to read out again, looks like we have about even distribution, around 33%, so a third each would consider themselves either in the in progress or the advanced stages. 17% would be early on, and then a 14% would be not sure there. So sort of people are maybe a little further along in using some of these sources, or at least on the journey.
That's great. That does make sense. We are seeing people that are investing in analytics, especially working with statisticians and other folks using pretty sophisticated techniques to try to refine and improve their selection. All right, so the first use case we want to talk about is opioids. And Rena, why don't you take it from here?
Okay, thank you. So as Roger had said, we really want to get into that 360-degree view of not only the member, so specifically to opioids. Certainly we want to potentially focus on the member outside of the FWA world. If there's collusion, that's certainly a different story and situation. But looking at that member, what is the persona of that member, which I'll talk about in a couple slides, associated then with the claims coming in, whether they be medical or pharmacy, and then the prescriber and provider profile. So we have some examples of that we'll show you here. So first, I think are aware of the challenge that we have in the cost impact of opioids. The largest number of fraud, waste, and abuse cases involve prescription drugs. I don't think that's any surprise, but the cost, especially on, and not only just focusing on the prescription drug opioid itself, but the cost to the medical system is really staggering. I mean, statistics show that for every $1 of prescription opioid drugs, there is $50 spent on the medical side, and those are in the emergency room visits, doctor visits, those members who are drug seeking and exhibit that type of drug seeking behavior. So it is pretty significant. One of the challenges we have had, particularly on the Part D side, that I believe has lended tremendously to this issue, is the lack of ability to, quote, lock in members on the Part D side. There was a Senate bill just passed last week. The House is looking at it as well, and they are looking at companion bills to this. But there were some, a Senate and a House bill also passed last year, and they've since been broken down, and this is the most recent one that has passed. And I think many of us are thrilled to have this. I don't think it will be easily administered like it is on the Medicaid side, so probably more to come on that when it starts to happen. But just to also share, in 2011, over 1.4 million emergency room visits were caused by improper drugs, and there were 700,000 inpatient hospital stays that are related to the overuse of opioids. So it's been recognized as an issue, and many of us have the challenge to see what we can do with that. So this might be a little bit busy, but just wanted to show an example of client data and the way that we are looking to overcome the challenge of opioids. There's lots of analytics out there that analyze by member and prescriber and pharmacy and things like that, which we have as well. But the newer way that we're looking at this and trying to think ahead is overlaying utilization that you would see here. This would be an example of utilization of one of our clients, and then overlaying that with the CMS heat zones. We also term those as MSAs, or Metropolitan Statistical Area. That's how it's done by the Census Bureau. So we look at that, and then we also intend to take we have very robust nationwide data on both the pharmacy and medical side, and combine those and combine that data across both payers and PBMs. So not only can we identify member drug-seeking behavior, because that's certainly something that we need to do and do today, but also our intent is to anticipate what is the potential next heat zone or heat city or heat county or zip code. By having the access that we have both purchase data and client data that we can look at, that gives us benchmarks and helps us identify and see where is that next scheme going to be. So not only identifying where's the next heat zone, but where's the next potential drug or the next prescriber that looks to be in collusion. And by seeing it graphically this way, we think is pretty powerful, and almost the way that you have to do it, because looking at claims in a spreadsheet, with the size of this data, it really doesn't seem to work as well. In the sense of, for many of us on the fraud side in pharmacy, we would never have thought lidoderm would become a fraud drug or a commonly, diverted drug. So things like that may not necessarily be an opioid-related drug, but are something that we can see, that we can anticipate, and then be able to proactively advise our clients and customers of what to watch for, and even taking that a step further, creating flags, looking at those types of things prepay, especially in the pharmacy space where that's, concurrent daily review is very common. So again, we think that the graphic display is very helpful, and then overlaying it with heat zones. These heat zones, as we all know, have increased over time. Every lot things, started in Dade County, and everything sort of went up and out from there. And so we just anticipate that these will not be the same a year from now or 2 years from now. So we want to be ahead of that in order to help identify and to help our clients. And then Roger, if you can go one more. Click, it should magnify there. Okay, thank you. So getting to a more narrow level, as Roger talked about, what is that relationship with the member, the pharmacy, the prescriber? This is an existing analytic that we have today that, again, graphically or geospatially shows the distance from the member to their physician, prescriber, and their pharmacies. The goal here would also be to pull in medical data where we also have either client data or nationally benchmarked data. So in the case of a PBM that wouldn't have medical data, we could put our benchmarked data here to show what are kind of the average physician visits and ER visits. And then if we have medical and pharmacy data for a specific member, we can actually show that and see what does it look like in terms of where is the member going? Are they going to a lot of emergency rooms? Are they going to, we see a lot of members going to nurse practitioners, kind of staying below the radar there by not going to physicians and things of that nature. So back to that non-traditional discussion, and Roger mentioned about the personas of a member that will help us. We are looking at that as well, and as an example, what is the persona of a member that is at risk for opioid use or is abusing opioids? What are their buying patterns? What's their income and gender? Are they in a household with children? if we have medical data, what kind of diagnoses are we seeing? Is it, sometimes we see alcohol dependency, pain of some sort, an accident of some sort, that benchmarking and trending all of those different data points and sources can help us predict and potentially intervene on someone who we can say they kind of fit this profile and they're at risk for opioid dependency, or they fit the profile, they are opioid dependent. This is a candidate for Suboxone as an example. We actually work with, on our life sciences side, we work with pharma manufacturers and do some of this work to help the manufacturers as well to, identify the appropriate drug therapy for these patients. It's not just about the fraud. It's not, it's about the care and getting these folks some assistance and intervening. So I think that's all I had on that one.
Great, thanks, Rena. So next, I want to talk about some work we are doing in the area of skilled nursing facility services, but to try to focus a little bit on how the provider elements are brought in, and then show some of the things we're trying to do to go beyond where some of the analytics are right now. So at a very high level, this is sort of a map of how we would approach analysis. So certainly we're going to use claims data. We're going to have our provider profile built. That includes various components. And in that funnel, we're also going to bring in things like member, clinical, financial risk, obviously those claims and provider profiles. And that's going to allow us to segment providers in different ways, to give some insight into risk or concerns about error for specific providers or specific claims, or claims for specific members. Allow us to look at certain factors that are more likely to lead to fraud, waste, and abuse, or less likely to lead to fraud, waste, and abuse. Part of this is about throwing away claims that have low risk of error, and then finally scoring that claim and prioritizing in the most effective way. So again, this is that provider profile showed before, but adding a little bit of detail about what are some of the new analytic components that we would bring in. So we would cluster providers by their relative risk for error and billing issues. So certain providers are, obviously, as is observed, more likely or less likely to have error in their billing. There's various factors that could lead to that. Some of that can be they're in certain zip codes where there's a high incidence of billing error because there's a known problem. Others could be they have had an observed historical rate of error. Another could be that the error has been increasing recently, so maybe they had staff turnover, they had some change in policy where they decided they were going to bill differently, better or worse. Also bringing in what do the patients that they treat, what are the conditions of those patients, what are the propensities of those patients, are those people people that are low utilizers generally, high utilizers generally, do they have a propensity where there are nervous patients where they are going to go seek treatment more often and therefore you're expecting a provider to have higher utilization, and ultimately some kind of developing almost like a case mix adjustment for that provider around their risk for overpayments and billing problems. Looking at some of the quality scoring and efficiency scoring that goes on in providers. So there's a lot of work around in the ACA and others, HEDIS scoring, to look at, is the provider rendering quality care? Are they efficiently rendering that care? So some of those components can be brought into a model for that provider to look at their payment risk and see whether do people that are better at quality or worse at quality, are they at higher risk for payment error? Are people that are otherwise viewed as efficient, or do they have certain propensities in terms of where you would expect them, how you would expect them to bill, but if a given provider looks different, okay, then that's a flag. And then there are certainly situations, facility type, size, etc. As we mentioned earlier, There's been a lot of physician practices that have been acquired. There's been a lot of consolidation within the provider space, and certain provider groups, integrated delivery networks, et cetera, are undertaking certain behaviors to try to maximize, optimize their reimbursement and their utilization. So they might be fighting against inpatient utilization going down, so they're working to focus to move as much as possible to outpatient. Well, that might indicate, if they bought a provider group, all of a sudden there's going to be a shift to outpatient services even within that physician group. And then specifically, what we're doing in situations that are lengthier services. So in the case of a skilled nursing facility stay, that occurs over an extended period of time, and often payers see multiple claims for that. So how can the information, not just on that initial claim, but about the provider and the member more generally, be used to identify, is that episode of care at a higher risk for error, even though that first claim might look fine? So one of the, for example, concerns is there are, in a skilled nursing facility, people typically go into a skilled nursing facility with a relatively high acuity, high need for care. And the whole idea of it is that the care is going to help them improve and get to the point where they can be discharged to home, so their acuity should go down. So they should become more healthy. So you would expect intensity of the services to go down, but that doesn't always occur. So one of the big areas in skilled nursing facilities is looking for situations of a specific provider or specific types of members where that services remain intense throughout. So bringing in those additional characteristics help that. And the reality is it's hard to do an audit until the whole episode is complete, but it's optimal if you can identify that episode earlier to take some action, either potentially to have somebody watch that closely before payment goes out the door, to do an audit, so when the final claim does come in, you already know you're ready and you can request the medical records, or even proactively, reaching out to the provider potentially and trying to engage there to try to ensure that the bill is correct the first time it's submitted. And what we've observed is a very high correlation, bringing in these other characteristics, between the score for that first claim and the final score for the whole episode after incorporating all of the claims. And so the opportunity there, I think, is by using advanced analytics, you can begin to move to a prepay mode. And one of the big concerns is if auditing a claim before payment is made, you have to do a couple things. One is you have to move very quickly, but another is you have to have a pretty high certainty that there is going to be an error on that claim, because providers will complain about dollars being withheld. They might say, we can't meet payroll, we can't pay our rent because there's so many dollars being withheld. But if, in fact, there's a very high rate of error in those claims that are audited, that argument is really reduced and there's much less abrasion in the process. So having that ability early to anticipate and score from the very beginning with accuracy is very important here. All right, and then the next piece we want to focus on is how a member profile and member information is relevant and useful in some of the analytic work that we do. Again, there's all components really involved here, but we're going to sort of focus a little more on how member information and member characteristics can be used. So in this example, we're looking at home health audits that we do. There's certainly increased utilization of home health services generally. That's been a trend over the last probably 5 to 10 years even. There's good reasons for that. It's a better quality of life, lower cost. It's better for a person to receive care in their home than have to go to a skilled nursing facility or even have to travel to the provider's office. So it's shown to improve in a bunch of ways quality and efficiency of care. So the data set that we picked here are claims that, universal claims, certain were selected for audit, and the findings rate on those claims we had was 27%. So about a quarter of those claims had errors, and the average overpayment on those were about $2,300. Now, just to be clear, that is for the entire sort of episode of care in the home, which is an extended period of time, again, like a skilled nursing facility claim, can be even longer than 2 months, but Medicare, for example, breaks those up into 2-month increments and pays based on 2-month increments. So that was for an entire, sort of home health episode. What we then did is we scored each of the members in terms of their risk, them by risk band or risk tranche, low risk all the way up to high risk. And what we initially noted, and this shows, is that as you move, so low risk on the left, on the left side of the graph, to higher risk on the right, as you move up into higher risk members, you're seeing more overpayments on a per claim basis. Makes sense. Those people are going to probably have longer episodes. They're going to have more intense services. So when there are billing problems, there's going to be more errors occurring, or more dollars associated with an error occurring. So the hypothesis here then is that we can use member risk scoring as an input to refine that selection. So claims that show a high intensity of services on members with low risk, my hypothesis is we'll have different audit outcomes. So what we're showing here is that we took the top 1%, top 2%, top 3% in terms of paid dollars on claims for each of those members' risk bands, so all the way from the lowest risk to the highest risk. And you can see, for example, for the top 1% of paid for 147 outlier patients, 271 claims selected, 271 claims there, 218 picked for audit, 76% had overpayments, and the hit rate there is 35%. So a higher hit rate with these high dollar claims than overall. The overall, as you remember, was 27%, so here are 35%, which makes sense. The higher average overpaid amount of over $3,000, again, makes sense. These are high paid claims, high intensity services. So just to summarize, again, for the entire group, 477 claims, about 78% of those claims were selected for those high paid claims. Again, end up looking at higher intensity services because that's where overbilling occurs. So the overall was about a 30% hit rate for the top 3%, about a $3,000 overpayment. Now, then we look at the specific output of the impact of member risk. And the key is the left part of this, the lowest risk band, which is actually the largest group of members, over 1,800 members of this total, had actually higher findings rates for those highest paid claims than the other risk bands. So what that means is, and that held true for the top 1% paid claims, top 2%, and top 3%. So what that means is those people who had low risk, meaning they would not necessarily be anticipated to need intensive services, when they got intense services, meaning high dollar claims, had a higher hit rate, and that hit rate was significantly higher. So for the top 1%, it was almost 45%. It was a 43% hit as compared to that overall 27% rate, and even for the entire band of the top 3% of claims at 35%. Again, same thing for the top 2% and the top 3%. So there's additional work to determine exactly what characteristics of the members and what characteristics of that risk score were relevant. That's just an initial view of the data that says risk did impact the findings rate here, and therefore is a relevant consideration to bring into the analysis. From there is, okay, it's like anything. When you bring in a lot more data and a lot more complex data, the questions become more complex, and that's where advanced and really sophisticated analytics come into play to say, what is the true correlation between this? Is there a way to refine that correlation? Again, remove some of the false positives, so things that have a low correlation, remove them and keep the ones that have the highest correlation. And the ultimate goal is to refine that much deeper and say, well, members with these certain conditions, because in addition to being of high risk, it's also a known thing, members are scored whether they have diabetes, whether they have congestive heart failure. That information is created by virtually every health plan is used in their disease management programs. Does diabetes have a high correlation? Does congestive heart failure have a high correlation? Does COPD have a high correlation? And how does that play out? There's additional layers of complexity to be analyzed, but it does appear, based on this, that there is a correlation. All right, so to just at a very high level go back over sort of what we're presenting today and the views here. There is certainly continued cost pressure in the industry. There's a lot of drivers of that, changes that have occurred in provider structures, how providers are delivering care, things coming out because of the Affordable Care Act, things like limits on MLR, medical loss ratios, that squeeze the administrative expenses of payers. And then there's really an explosion of data. So we are in a time where literally the amount of data created each year, I think, is bigger than the historical amount of data that exists in our world. It's just with all of the tracking devices and electronic medical records and all of these various things that can gather information about people and what's happening in the world, there is so many sources of data. So, and that a lot of that data is very complex, but there's real opportunities to use that data and bring additional insights. Well, what's the role of analytics? And ultimately, it's sifting through that data. So it's clear that experience is vital here. This is not something where analytics is the be-all, end-all, is the solution to all these problems, but it is a necessary component because smart people can only think of so many things and they can only investigate so many things. What they need is really tools to point them in the right direction and help increase the effectiveness of their work. So tools that can sift through these large and diverse data sets, and ways to build more effective member and provider profiles that improve the ability to focus our resources that are limited on the right things. And in terms of sort of takeaways on the use cases, there's a lot of great ways to use benchmarking and other data as evidenced by, as sort of illustrated by our opioid work, to display data in ways that can help people quickly see patterns. There's also real value in additional work around understanding provider characteristics to improve prediction, as well as in the case of members, looking at member risk and other member behaviors and attitudes that will impact prediction. I think we have one more poll, and then we'll take some questions. So I appreciate the time, everybody, and thanks very much.
And thank you, Roger and Rena, for guiding us through that content portion of today's call. We do have one last question. We did receive a lot of questions through the portal, so if we could please just quickly launch the polling question, and then we'll be able to get to the great Q&A. So this one's real quick. We're asking, what type of analytic resources do you use today? Do you have an internal team to help support with that need? Use an external vendor, a combination of the two, or if you're not sure, we have an option for that as well. Looks like about 50% of people have voted. Let's go ahead and close so we can get some of this Q&A here. And the results are about half of people are using a combination of internal and external. A third are exclusively using an internal team, and then we have a few folks that are 7% are using external, and then 8% would fall in the not sure category. So thank you everyone for your responses in our 3 polls, and let me just dive right into some of these questions here. So I have one that we got early on, and it I think comes from our first poll question. It's asking if we can expound upon what we mean by provider and member demographic data. So I don't know if Roger or Rena would want to take the first crack at that question.
So Sean, I'll take the first crack, and then Rena can certainly jump in. So demographic data, maybe it's easier to illustrate that by a member. So that is information like age, sex, which are very easy to get, but also information around income level, education level. So there's definite data to be captured and information that can be very granular down to, based on knowing where people live, what's their income level, what type of education, and what industries do they work in. And those kind of things do show patterns in terms of propensities of members to be interested in certain things or engage in certain behaviors. That's pretty developed on the disease management side. So how do you get a person to engage in disease management or to engage in certain behaviors? It's an emerging thing in our perspective in using those kind of, not age and sex, but other things around industry, education level, income level in the payment space. On the provider side, again, it would be similar type things. You would look at, do they engage in certain additional training? What specific sub areas are they working in? Do they conduct research or not? Are they in a large practice, a smaller practice? So there's a bunch of information you could capture about, and obviously age could be relevant because of when they were trained and where they were trained, and certain propensities based on where they were trained and what the sort of philosophies they might have been brought up in. And some of that does blend into some of the behavioral work that is done. There's work done around looking at what sort of propensities members have. It's a little more focused around, as I mentioned, behaviors, what incents people, how they like to be contacted, how they don't like to be contacted. So that they want to be outreached via letter, via email, via text message. Some of those things are a little less obvious how they might impact payments than others. And I think that's where the complexity comes in, certainly, is there's going to be some things that you can look and say, well, that seems like a pretty obvious thing that's going to impact potentially some of the risk of payment errors. Other things are going to be less obvious, but analyzing and digging down and to look at that correlation can actually reveal specific clusters or subclusters. So if there's one provider that's identified as a problem provider, what are other providers that look like him? That's done now, but I think there's additional work to be done in terms of layering deeper about, well, where did that provider maybe go to school? What hospital did they train at? What hospital did they work at? Are there certain protocols that hospital appears to use versus another hospital, for example?
Great, and I think that also touched on another question we received on what type of data is captured in behavioral and attitude queries. We got a lot of questions here around, is this presentation going to be available after the fact? We have recorded, so if you have colleagues that weren't able to make it, as a part of that follow-up email that will receive the link on the CPE credits, there'll be a link to a recording as well as posted on our website. We have a question here on claims, and if we're using denied claims in addition to paid ones in our analysis to determine chronic conditions.
My understanding is that all of the claims data is brought in terms of determining what specific conditions a member has. And sometimes it's not, some things is obvious whether a member has a condition, right? So you see the diagnosis on a claim. Other times it's a score of, are they emerging for that condition? And all of the claims data, and as well as things like lab and biometric information, so actual labs values to show, is that person emerging, borderline diabetic, borderline COPD, whatever it is, go into the analysis.
Okay, we have, let's see, time I think for just one last one before we reach the top of the hour here, and that is, could you describe how the provider profile that we're working on, how it's different than other types of analysis? Give an example here of a peer comparison.
Yeah, and I think coming back to the core message, this is more evolutionary from our perspective than it is inventing something out of whole cloth. As we said, we certainly see and understand, and as the poll question showed, people have been working in these areas for many years and understand the need to do more here. And so it's been very common for years for people to do peer comparisons and look for various provider characteristics that might increase risk. So is the provider under sanction? Are they, treating certain members that are known? Are they working with members that have another provider who's also been known a known, problem provider, that kind of thing. It's a matter of then taking that to the next level, adding in some of these additional levels and data, and putting that on top to say, okay, well, we have our base view of this provider, but how can we refine that in specific pockets? So, we might know the provider is an overall high utilizer or overutilizes certain claims, but is it only on certain types of members that have high or low risk? Is it only when they're in a certain office? Is it only when they're otherwise engaged in certain behavior? So layering those additional things and then analyzing and feeding that back, part of the point maybe we didn't make enough is this is really in our experience an iterative process. It's not something where you have a provider profile or a member score and it's static. No, in fact, they have to be updated. They have to be updated with all kinds of information, new claims data, new results data, new demographic information. Somebody moves, changes their practices purchased. All kinds of things can happen that need to be brought back in on an ongoing basis into the analysis.
Great. Well, I believe that's all we have time for. So if you did submit a question, we'll have someone follow up with you after our call today. I'd like to thank you, Roger, and Rena as well for taking the time to walk through the presentation with us and answering some of the questions here. I'd also like to extend a thank you to the audience for taking the time to join with us today. If you'd like someone from CO to get in touch with you based on what you've seen today, or if you have any other questions, please visit the Contact Us page on our website. Someone will be happy to follow up with you shortly. And with that, we'll conclude with today's conference. Thank you again for your participation. I hope everyone has a wonderful rest of your day today. Thanks.
Thank you, Sean.
Thanks very much.